Welcome to the Living Medicine Podcast, where we talk about ethical medical use of psychedelic psychotherapy, teaching skills, examining the issues, and interviewing interesting people. Now let's start today's show.
Hi, everyone. I am Dr. Sandra Newis, and I am excited to be here with Dr. Erika Czerwinski. Erika and I actually go way back, and I'm delighted and honored that she's choosing to be here with us and share her knowledge about clinical applications of psychedelic-assisted psychotherapy, ketamine-assisted psychotherapy in particular. And Erika is a licensed psychologist with extensive training in depth-oriented psychotherapy, attachment theory, trauma theory, and group therapy. She is certified by the Living Medicine Institute and IPI in ketamine and psychedelic-assisted psychotherapy. And she has been facilitating ketamine-assisted psychotherapy since 2019. Prior to that, however, she has 2 decades of clinical practice, and she spent the last 15 years incorporating wisdom traditions, rites of passage and ceremony, yogic philosophies, and meditation into her work. Dr. Czerwinski maintains a private practice in Asheville, North Carolina, and she is on the board for the Western North Carolina Psychologist Association and Horizons at Carolina Day School. And Dr. Czerwinski and I go way back to wilderness therapy days, where I was wildly impressed with her clinical knowledge and that kind of a similar, in my opinion, kind of integrative approach to different types of using experience and different states and combining psychotherapy into a more experiential oriented tradition. So I am excited again to be here. And thank you so much for joining us.
Thank you, Sandy. Thank you for having me. And yeah, I think one of the reasons why I actually really love the psychedelic work and the ketamine work is because, much like wilderness, there's a way that we get to bring different things together. And I think that it makes it really rich for me. So I like that.
Well, it's interesting. I've always thought of wilderness as being kind of its own altered state work, and have really begun to broaden kind of when people say I'm into psychedelic medicine, I say it's really about non-ordinary states of consciousness and altered states, not just the medicine itself. So, and I know that's something that you've also been into.
Yeah, it's how we get there, right? The same thing with rites of passage work. It's how we can provide an environment that helps people drop into another reality in terms of their own inner world. How could they find a place that they don't usually get to? So that's, wilderness as well as psychedelic work.
Great. Thank you. So I know that you come from a particular type of tradition, and as do all of us. I obviously am aware of the fact that it's more eclectic and that you used other tools as appropriate. But if you were to describe your clinical orientation, how would you describe that, kind of with an eye to how that might inform your work with ketamine?
Yeah, originally I was trained in graduate school, contemporary psychoanalytic. So I think, have a strong foundation, or what I first start listening to material from is from that lens of depth-oriented relational work. So what that means is, how did this person's experiences in relationship start to create patterns of how they relate to themselves in the world? That's a lot of that basic and foundation, and then also with contemporary analytic work that brings in a lot of the attachment piece too. So attachment lenses, how did they find safety? As little ones, how did we find safety and survive? And how did that play into the relational piece of how we respond to others to get that safety?
Right.
And then, so those are 2 parts. And then also I'd say bringing in some of the family systems work and group work too. Mm-hmm.
When you say family systems work, how does that kind of show up for you in terms of that?
Well, I think that would be more with my work with couples and my work in groups. So you have more family systems work. I look at in a relationship that we have multiple people in the room. How are they responding to each other, and what's the other person representing, and how do I support them in seeing their patterns of how they're relating to others? So what's the system that's happening?
Well, and then so I'm wondering, I know a lot of what you're doing, and we're going to get to that. I know that you're doing group work and that's an exciting area. But in the individual work that you're doing with psychedelic-assisted psychotherapy, I'm really curious about how that particular orientation plays itself out for you. So you mentioned, again, psychodynamic and depth work, heavy relationship focus. It sounds like heavy emphasis on early relationships, and you said what the little ones do to get their needs met and to find safety and security. And so I'm just curious how that plays itself out for you in the work that you're doing with actual clients.
Mm-hmm. I mean, I think in order to answer that question, I think we first have to distinguish between psychedelic work and psycholytic work, because that work with psychedelics, when individuals are in that deep internal state where there's so much stimulation happening from the inside, that working with them clinically or therapeutically on the medicine isn't where the richness is. It's usually having the psychedelic experience and then working that in the integration sessions. And that's where the rich work can happen. In the lower dosed sessions, so say if I'm having someone come in for ketamine, and on average, if we're starting that, on average, people starting at that 0.5 dosage, that's most of the time, it's a fairly psycholytic dose, meaning it's a lower level stimulation of having the psychedelic experience. And so they're really verbal. They're able to be verbal the whole time. They're able to maintain that there's an outside world happening at the same time that their inside world is happening. So there's a ability to keep both places in their awareness, as opposed to the psychedelic space where you're really taken over by that internal experience.
Okay. You mentioned, just as a little aside, you mentioned that 0.5 dose range. Can you just speak to that, just in case people are unaware of what that means?
Sure. So when we're doing ketamine work, and each individual is going to respond differently to the medicine, but on the basic realm, if we're using between the 0.5 and 0.75 mg per kg per kilogram of weight, puts them at that average space where that is what researchers said the sweet spot for treating depression. So we're usually starting at that lower dosage and then seeing how someone responds and then adjusting from there. And that's both with a ketamine induction series, if they're coming in for a treatment with depression, where they're doing that typical 2 times a week for 3 weeks, or if they're coming in for a one-off session or to really have it support their work with therapy or trauma. So we're not trying to do the induction for the treatment of depression, but we're just using it therapeutically.
Right. Thanks. So back to the question about how does that kind of more psychodynamic or psychoanalytic lens kind of play itself out in your clinical sessions? You said, okay, well, first we have to clarify the sort of psycholytic versus psychedelic dose range. So that said, I'm just really curious, like if you were to say, this is what I do that may or may not be different than others, because I totally recognize, I don't actually know what you do, and I do this full time, you do this full time, knowing that we don't actually really always know what a session is looking like. It's that kind of black box of trying to unpack that. Mm-hmm. But if you were to just speculate on that, how do you think that lens, that theoretical lens and that view and how you conceptualize the client, how does that show up differently for you in an actual session?
Mm-hmm. I think however we work clinically without ketamine is how we're going to start working with the ketamine. And so for me, I think it starts with, how am I attuning and listening to the material? And what am I paying attention to? So I think as clinicians, we start to listen to and pay attention to different things. So how am I looking at the material and just listening to what are the themes that are coming up, especially in a psycholytic or a psychedelic session where psychedelics often they're not speaking as much. Psycholytic patients will really often speak quite a lot. So I'm listening to the themes. I'm looking at the materials through what are the feelings and the experiences coming up in the room. I think one thing that puts analytic work, separates it a little bit from some other, is really paying attention to the transference and working in the transference. And what that means is we're allowing the projections of the patient to come into the room and into the relationship. And so if a patient is experiencing something, for instance, a patient might be apologizing in the session. They think that they're not doing this right. I'm not doing it right. You probably think I'm doing this wrong. How do I respond to that? Or in the integration work, how do I respond to that instead of saying, wow, you were doing that great. You were doing it right. I'm wanting to understand what that meant more. So I might try to open that up and say, when you said you thought you were doing it wrong, and I thought that you're doing it wrong, tell me more about that. What was I thinking at that moment? So I want to understand how they're experiencing the projection, and how do I play into that relationally. I could give you, I think, I could give you some examples as we go through this, but I think to get the basics down around what are some of the things that for me, how I understand analytic work is listening to the material, attuning in, working in the transference. I also think analytic work really pays attention to the contemporary analytic, relational analytic will pay attention to what is the therapist's unconscious process and what's the patient's unconscious process. How are we in the room together regulating in a way that we're really experiencing one thing? And so that might be called reverie. That might be called we're attuning. And so how does my thoughts start to reflect something that's happening with the patient? And there was a analyst, Wilfred Bion, who would say each session we want to go in without memory or desire, because what happens in the room is what we're going to be working with. And the use of reverie is that giving valence to the fact that our collective experience is creating something together. And so that's another piece of it. And then I'd also say the use of interpretation, which is also really an interesting thing to talk about with psychedelics, because we're really taught that we really go in and allow that patient's experience to be its own space without interjecting anything of our own. And so when does interpretation come in, and how are we as analytic therapists working with that?
Well, that's really interesting, isn't it? Because really, like, that is the prevailing view. And that's what we're taught in training programs, that we kind of allow and support and be with. And I'm really curious, like, when might you use interpretation? And I get that it's going to be variable and it's going to change per client and all of those things. Like, totally understand that. But and I also just want to add, for my own point of view, that I think that's the unique role of a therapist versus like a psychedelic integration coach or a sitter, is that there might be more opportunity for that. And, there are pros and cons to that. And that's kind of a controversial point of view. So I'm really curious what your thoughts are about that.
And I think it's about also, how do we take risks as therapists, and how do we play, and how do we allow ourselves to find, how do we bring ourselves into the room in a gentle way where we're not coloring somebody's experience, but they're not completely alone. Because I think that that's an important thing, that anything that happens, as we know, in the room is influential. That's the whole premise of setting, right? So we know that by me being there, I'm already influencing that person's journey. So if they're having an experience, and if I sit with them, it's going to be different if I'm not sitting with them. So I know that there's already a transferential relationship happening. And so how and at what point do I begin to use that? And I think what I try to do is, in my psycholytic sessions and even the psychedelic sessions, let that experience happen. But when they're on the tail end, when they're really talking, when they're quite aware they're in the room, when they're aware that I'm there, and it's at the tail end of the therapy, I will begin to use interpretations, and that will seed things, and that can seed relational patterns that happen in the room that then we work on in integration. So I think that giving ourselves permission to play with how we work clinically, and how does that impact, and look at it and see what happens in the room.
Well, that's super interesting too, because what I heard you just say too is that it depends on where you are in the session, that there might be some more, is that accurate? That there might be some more room for interpretation, kind of inserting yourself a little bit more into the mix, as the person is what I refer to as the tail, where they're kind of coming out and they're coming back into their body, versus when they're kind of deeper in it.
Yeah.
Did I hear you correctly about that?
Yeah, that's exactly right. I think I've seen a lot of transfer, or I've seen more transferential relational things come up in sessions around touch, because as you know, with psychedelic work, there is a real need for touch and going over what the protocols are for touch and having the patient be able to name what's comfortable or not comfortable and giving permission and accessing how do we use touch. Now, in regular therapy, we don't use touch. And so touch becomes a really powerful exchange, a relational exchange between two people, the therapist and the client in the room. And what happened in that moment is relational. And so I am going to be working in a transference later in integration when things like around touch happen. Did I touch in the right way, or did they have an experience? That did happen recently, where a patient who experienced themselves as very careful and were always wanting to make sure they're doing things right, the touch wasn't great. And it took them a while to be able to say, no, can you change that? And then that became an important part of the work in integration. For them to just say, I don't like that, was a very big deal. And that was a relational exchange that happened. They were perceiving something in me that, oh my God, they're going to get angry that I'm saying this. And so there are things that happen in the relationship in psychedelic work that become very rich material for integration processing that reflects patterns that have to do with the patient.
Well, and it's so interesting because for me, and I'm curious if you agree with this or not, like that intensity of that relational dynamic and that energy, like that comes up between you and the client, is something that isn't talked about enough. I mean, we talk about it generally, but two, it can become very preoccupying for the client and for me as well. I mean, and so what I'm hearing you say is like taking that as being a critical part of the work.
Yeah,
really
completely.
Is that accurate?
Yeah, I think it is. And that's how I work without ketamine. And so it's going to be in ways how I work with ketamine, allowing that we're knowing how to offer space and hold the right container for the patient, which is a safety container. But if we take ourselves completely out of the room as if we're just going to be the good object, that's actually allowing them to rely on defenses that need to be seen and understood. If we're just only the good object, I know I'm not going to be the good object all the time. Sometimes I'm going to do something wrong. So I need to be able to look at those things that actually become helpful clinical moments because they were real exchanges that happen between two people that's special and intimate.
I love that. It sounds so just authentic.
Yeah.
Being really real with what's coming up and being really transparent with that. And
yeah, we need to, I think as clinicians, we need to be able to be aware on one hand what's happening in the room and attuned enough to notice things and then be unafraid to say them.
Yeah. Yeah, it's interesting. I mean, that's one of my favorite pieces about psychedelic work is to be able that level of authenticity and, how being able to be transparent and just really in there, like with the client is just, I mean, it's transformative for me.
Yeah. And that vulnerability, right? If we don't have authenticity with vulnerability, then there can be something dangerous. Right. Like the patient's very vulnerable in this state. And so if we're not being authentic and attuned, then they might perceive and feel something that if we're not acknowledging that can be then retractive and shut down. So I think that space of being able to attune and be authentic and caring is a really important part of this work.
And I love that. And I think it's like, that's what I love about this work. And it's also just such an invitation for therapists to, hey, like we can be real with this. The clients are super vulnerable. Can we also show up that way? And also recognizing the importance of us doing our own work on that level so that we can.
Exactly.
So I wanted to just kind of circle back for a minute. You mentioned transference and just, in my mind, like that's essentially what we're talking about here with the authenticity and the being able to show up in a transparent way. But I also know that there can be more with that. And I'm really curious just what your thoughts are about the place for that, how that might show up for you in an actual session, and what that, how you work with that.
So the question is, how do I work with the transference, particularly with ketamine?
With ketamine, or and in the session and after the session. I mean, we just talked about authenticity and transparency, and to me, those are part of transference. But they're also, transference has a more specific definition in some settings. So I just want to make sure in some circles that we're kind of talking about it in the way that you mean it.
How we're defining transference. So I see transference is the unconscious relational experiences that someone has, and beliefs, unconscious beliefs, and how that gets projected outward onto a relationship. So, if we look at a therapeutic relationship, and you've been working with somebody for a while, and they start to experience you in the same way that they experienced their father. And that would be the transference that they're having to you is similar, and like they're now relating to you like their dad, like you're their dad. And that's a transference. And so then if I accept that role and begin to understand that this is how they're experiencing it without trying to make it go away, I then have an opportunity to work within that kind of relational pattern to help them understand it and work through some of the experiences that have created true, good, and important experiences that have created that projection, and to work with it in a way that helps them create more safety and create more expanded view that isn't just a movie projector onto a screen. And that's where more contemporary analytic work knows that my experience and who I am plays into that intersubjectivity. It's not just the patient's experience, it's mine too, so that we're looking at it from an intersubjective lens.
I mean, what comes up for me when you say that is relationship safety. And I'm curious, like a lot of people come in that I work with that are very fearful of relationships, whether it be, grounded in parental relationships or other important relationships. And I'm just kind of curious if you see that as well, and what your thoughts are, if you can use the transference to create safety, or how do you see that playing itself out?
Well, I think in ketamine work, because we're not working always in very long-term ways, on average, say I'm doing 5 prep sessions, which allows me to know their history, allows of both their relational history as well as their psychedelic history, and think about what elements they're really coming up for them that they want to work on. So this isn't long-term work for the most part. I do have some of my patients that are long-term that do ketamine work, and that is a richer experience because there's more relational history between the two of us, and I know them a lot better. But if it's someone coming in to work on something particularly with ketamine, and then they're going to go back to their other therapist, then I'm not necessarily working in the transference as a relational transference, but it might be an enactment or something that happens in the room that they believe they have a perception of me that then we get to work with. So it might be a smaller chunk of something that happens, a momentary experience that gets projected outward. For instance, had another patient who really struggled with a lot of shame and had a history of childhood sexual abuse. And they had a very big feeling come up for them in the session. And I was encouraging them to stay with it. They really wanted to vacate and be like, I don't want to do this. I don't want to feel it. And as you know, in psychedelic work, we ask them in a gentle way, can you stay with that? Can you lean into that? So when they were having a big feeling and I'm encouraging them to stay with it, they did. And I had this flash as the feeling is very big for them and they had such an overwhelming experience of shame. I had a flash of this person being really young, and my connection was to sexual abuse. And so this is a place where I'm allowing my reverie to inform what I'm thinking. Now, I don't know if I'm right or not, but I then, as they were sharing that how small they felt and how big the shame was and how hard it was for them to be seen. And so I had said something like, what's it like if you feel that feeling and know that I'm still here with you? And so that they were feeling the feeling while someone else is there. And that's both really challenging, but also somewhat comforting. It's both. And they were able to stay with that feeling and shared more about it, where it was in their body, what was the experience, what was the belief that they were having. And I then took a risk, and I did say something about wondering about this feeling and being small. And so I was using my reverie, and I did. And this also, I will say, this was at the very, very end. So they were very verbal. Again, we talked about that tail end of being in the ketamine session. So I used an interpretation, and they said, yes, right now, my mind has a memory of, and then they started sharing a memory from when they were small. And so that was this collaborative work that was co-created from what I was experiencing with them and giving them space, but I'm still offering something. And so I think that's an example of, in these lower psycholytic levels, how the therapy was happening in the room without it just being them alone in their experience.
I love that. That sounds really, really powerful. Just giving the client such a different felt sense of experience of being in relationship with you during such a time where we have the opportunity to make such profound change.
Yeah. And then having that space, the amazing thing with ketamine too, is that then you see each other the next day when they're not in an altered state, but still really remembering that experience, and they come back and speak about things. And I do think with psychedelics in general, it's evocative, right? It either, and ketamine specifically, I have a lot of my patients that connect to memories that they have, but they haven't delved into in a long time. It feels a little safer, or it feels more alive in their body to reconnect to those experiences.
I love that. One thing I think that you and I really share as I hear you talking is just this importance on the relationship and how important that experience of the relationship, not just having the relationship, but the experience of the relationship is. So, and that leads me to another question that I wanted to ask you is, in what way, if at all, do you see attachment issues showing up for clients in this space?
When I think about attachment issues and how someone relates, are they more avoidant? Are they more reaching out for connection? I actually think I look more at the fine-tuned relational patterns. I do think that attachment patterns and ways of relating will come up. I think I get a little more nuanced with the flavor of certain feelings, if it's feelings of unworthiness or not wanting to be seen, which play into attachment patterns. But I think I go a little bit more granular than that. If we had a broad scope look at attachment patterns, and I do a lot of attachment work in my couples work with ketamine, I think I work more granularly in that.
Right. So one of the things that I didn't ask you in the beginning was just if you want to just give a really brief introduction to kind of, the populations that you work with and different routes of administration and just kind of how that might work itself out for the population that you work with.
Sure. I think I work with three main populations. So in my individual private practice, I see patients that are fairly high functioning and can, I guess I'll say they're of that normative set. I also do work with a residential young adults program, and those individuals come in with high levels of depression, anxiety, OCD, a mix of areas that would need working on. And many of them come in having had lots of treatment before that hasn't helped. And so I work with them with ketamine mainly, I think, to work on some of the deep depression, suicidality, intense trauma or anxiety. So that's a different subset. And there are also mixed with personality disorders. And then I also do group work, ketamine group work, which is totally separate as well.
Right. So you mentioned personality disorders, and that in my experience, that's been kind of a very controversial area that, psychedelic-assisted psychotherapy or ketamine is specific, not good for personality disorders. And yet, as we move more and more into higher levels of clinical sophistication and it becomes more awareness in the mainstream and people come in for a wider range of issues, I mean, it's likely that we're going to see more and more of that. You mentioned specifically that you work with it. So I'm curious what your thoughts are about that.
Yeah, I would say I don't work with ketamine to treat the personality disorder, but I work with the ketamine if there's multiple layers that this person's coming in with, and if they're struggling with suicidality or have a treatment, as they've called treatment-resistant depression, or depression that hasn't really been able to be met or alleviated, I'm not going to not see them because they have a personality disorder. And so what I've noticed in individuals that struggle or that have depression as well as a personality disorder, that as the depression starts going down and they're starting to feel more active and better, the personality disorder traits will come up. So that's, one of one of the things that I've noticed. But at that, and then it allows their home treatment, the program that they're in, to work more heavily on the personality disorder because their depression is not weighing them down so much. And so that's been an interesting segue, start alleviate the depression and then work with personality disorder more deeply.
That's so interesting that you say that, because one of the things that I noticed for me, and I'm curious if that is the same for you, which is actually one of the reasons I asked about attachment, is that clients that I work with who have personality traits or kind of underlying personality patterns, what I witness is that they might start to do more of a push-pull in the relationship. And they might see that, oh, maybe I want to do some sessions by myself, or I'm not sure if I want to keep doing this. And in the beginning, I was like, oh, maybe I'm not doing this well. Now I see that more as an attachment dance, or, which can be related to personality disorder traits. And I'm just curious if that is similar for you.
I like the distinguish. I like that you're adding in the foundation of attachment for what we have called personality disorders, because you do not have a personality disorder without an attachment disruption. So I really like that you're naming that. And I have seen, again, this is where if you have a patient that's saying, oh, I think I'm going to do it alone this week. Whoa, what great opportunity to go into that relational work with them. And I have had that happen. I have had individuals who struggle more with personality traits that it will come up in the middle of the treatment because they're activated. And then how do you work with that in a regular session that they're not on medicine? So I do think you can take the experience that comes out of what happens, what's the transaction that happens in the psychedelic work. Oh, I don't want you there today. Well, then it's not just, well, okay, fine. Don't have me there. I might say, yeah, okay, let's try this one without, but then I'm definitely going to come back and talk about that thing. What is it now in the relationship between us that's coming up? And so that's really rich material. So it can be an instigator. Bring the material into the room.
Well, and it's interesting because it's so easy to say, okay, well, I don't know, for me, like, oh, they don't want me, or I don't know. It's almost like it's an interest. I agree with you. It's just really rich. And it's also really great learning for me to kind of notice my relational dynamics with the client as well.
Yes.
So great. Well, so I wanted to just switch gears a little bit. With the psychedelic renaissance on its way or in full swing, kind of depending on what your point of view with this is. And, there's a lot of discussion about differentiating different medicines. Do we or don't we need different medicines, and what are the benefits of the different medicines? And I'm really curious what your thoughts are about that. Do we need to do that? And obviously this is a really broad discussion and could be kind of a whole discussion in and of itself. But why would we use ketamine versus something else? Obviously, ketamine is legal right now. So let's just own that. Like, ketamine is the only thing that's legal. And while there's opportunities in the underground, that's not what we're talking about here. So to me, that's a very basic one. But beyond that, assuming that, other things come on the horizon, MDMA is likely going to be legalized soon for therapeutic use within 2024. What are your thoughts? Where does ketamine fit in that?
I love this question because I think we're going to have so much more opportunity when other medicines become legal to really have this differentiation of oh, what does this person need? What's going to be most suited for what they're coming in with? And also chemistries. Like, I know my body chemistry does not metabolize amphetamines really well. So it's really intense for me to be on MDMA because I don't break down amphetamines that well. So each person has the biological part, and then what's the clinical part that they're needing. I mean, ketamine, what I've seen and what I love is that, yes, we know it's a really, really good for depression. I also see it helping the subjective space, that the objective observer in a way, that have a little bit more distancing from some of the inner experience that they have. And also because it's such a kinesthetic medicine, I think it's more kinesthetic than some of the others that people will really feel. They're on a roller coaster, or they're moving, they're spiraling, and that brings up body sensation. So it brings people into their body. And I also find, I don't know if you found this, that a lot of my patients will have it instigates memories. Like it'll trigger up memories from the past they haven't thought about. So I think when I'm looking at, okay, if we used to call it differential diagnosis, like differential assessment of what medicine should you go on, I love the work that's happening with MDMA and trauma. I mean, that is such a graceful, holding, gentle, conscious way of doing trauma work. And I also know that we don't have that available to us. So I'm doing trauma work with ketamine, and it's working, right? I mean, people are really making the body. So I particularly love ketamine also because it's so short acting, and that we can have a 2-hour session, and that 2 days later we can have a 2-hour session. It's less intense on the body than some of the other medicines. And so it allows to have more repetitive uses to go in, as opposed to, I think, some of the other medicines that do better at maybe a one-off. Like I think psilocybin does a lot with the one-off. And these are just my personal, this is not scientific. This is my personal assessment of it. So am I answering the question?
Yeah, I just think it's really interesting. I mean, I'm just going to zero in on what you said about like the trauma thing, just because it kind of cracked me up. Like the prevailing view in the field, even just a couple of years ago, and in a lot of circles now, is that we don't use ketamine for trauma. But I think that, to me, that's the really significant differentiating piece. One of them with ketamine-assisted psychotherapy versus ketamine treatment alone, where somebody's just doing kind of the more pharmaceutical and they don't have a therapist, is that, you and I both have an extensive background in working with trauma. And when I have clients that come in with trauma, we're going to do trauma work.
Yeah.
But I don't think it like naturally happens that like
when do we have depression? We don't have depression without trauma usually.
Right. Exactly.
So the trauma's always kind of there in every human, just at different levels. So I think we go with where the medicine brings the patient, like wherever it goes, we are there with them. And sometimes that's a lot of times it has to go in with those deeper pains of trauma.
Right. I love that. So 2 more questions that I want to ask you. Now, I know that you also run CAP, ketamine-assisted psychotherapy groups. So that's super exciting, really cutting edge. And I'm just curious, if you could just tell us a little bit about that. And then how is that different than individual?
Yeah. Well, I love the opportunity, given my experience with rites of passage work and some wisdoms traditions, that I get to, I think for me, it's like I get the excuse of actually bringing in more of the ceremonial piece and the sacred work, which I don't get to do in the same way in the office. This is my office, so it's pretty a normal therapy office. But when we get to have a group on a retreat land or a separate space, I get to bring that frequency of consciousness in. And so what is it like to hold a type of consciousness for a group that everybody drops into that level of consciousness together? And then the cool thing about ketamine in group is that it's amazing how one person will be talking about what came up for them in their journey. And then someone across the room is like, oh, wow, you were speaking for me. Like, this is what's happening. So there's this interesting connectivity that happens in groups, and people, I think, then have this experience of feeling seen and being vulnerable together, and having a very vulnerable experience going under a psychedelic together in a very safe container is often a very profound experience. And it's also more inexpensive. So that's an asset too.
I love that. It definitely is more cost effective. And I think that we're going to see more and more of it. And I just want to speak to, I'll talk to clients and they're like, oh my God, I couldn't possibly do that in a group. And in a way, for me, that's almost the reason to do the group, and also speaks to how important it is that we have a, trained and skilled facilitator who knows how to manage the dynamics with that, because it is a vulnerable state.
Yes. And to be able to hold that, both the combination, what I love about it, just how it fits for me as who I am as an individual, is I get to both use my clinical skills of navigating and facilitating group with this other precious part of my life, which is more of the sacred and the spiritual work of being connected to things in these larger realms of being connected to the earth, being in nature, being present to the larger unseeable realms.
I love that. So that brings me to my last question. So what about ceremony? Obviously, you just said this is a very precious to you, which I appreciate that word, part of your work. And just, how do you bring that in?
Well, there's two, I guess I'm thinking of two parts. One is how I bring it in the room with my individuals, and in individual work, I spend a good amount of time. I think it's so important for us to do really, really solid prep work. And for many people, that might be 1 or 2 sessions, but I really think on average, if someone's new to me, it's going to be a minimum of 5 sessions. And that allows us to get distilled down to what's really important, what's sacred to them, what is their way of connecting to themselves, and how do we bring a few of those elements into the room to make this special. This is a special thing that we're doing. And I will say that. I will really say, this is special what we're about to embark on. This is an opportunity for us to reach places that maybe you haven't reached before, but you're spending a lot of money and you're putting a lot of energy into this. So how could we make this really sacred? What's sacred for you? And so I'll really try to dial into that particular individual's way. And that might be maybe they bring a photo of something, or maybe they bring a totem that's saying, hey, we're marking this as a beginning session. Now we're doing that in a doctor's office. So first the doctor will come in. I work with IV mainly, and they'll come in and they'll do their medical things. And then it's okay, now we can start. So I let the medical stuff be in the front part, and then we're setting up our space and starting. So that's individual. And then in the groups, that's where I really love bringing in the sacred parts, because when people, as soon as they walk into the space, there's an energetic field, and that's kind of sounds woo-woo, but there's a way that we're creating a space that they can feel. And that might be, how have we prepared the room? How have we started? What threshold are they crossing to know, literally a doorway? We are now in a sacred space. And how do we create that? By are they bringing an altar item, and how are we creating altars together? So bringing that element of ceremony or intention, I think intention really goes along with ceremony, into the group work makes it for me exciting and powerful.
And I think it gives such a wonderful anchor point too. It's a very tangible, experiential piece that I think, especially for me, with people who've had so much therapy, to also kind of be able to weave in together that, solid clinical lens that you so obviously have, with this anchoring within the ceremony and the experiential components of that, whether it be a felt sense or a sacred object or even just a visual, something that's really different, kind of like you said, connecting them to those larger realms. I love that.
Yeah. And I think this is something that, the psychedelic renaissance in a way in the world right now is bringing to us. Really, why are we doing it? To expand our consciousness, to get to places that we may not be able to get to. And yet, do we always need psychedelics to get there? No. We can do this, as I know, because you're also in the field of wilderness therapy, where we never use psychedelics, but they get to these other deeper places. And so I think humans right now are needing ways to touch into deeper places within themselves. And psychedelic containers are one way of doing that, not all the ways. But if I can couple that with some of these other modalities, then it's great, more powerful.
Well, and what I hear there is building bridges from other non-ordinary states of consciousness, or other ways of connecting to yourself on a deeper level, or bridging the psychedelic experience or the ceremony, and just to kind of continue to build bridges into consciousness expansion far beyond psychedelic work. So great. So I'm just wondering, is there anything else that you want to say before we close? Anything that kind of is up for you, or that we didn't cover, that you want to add in?
I think I would want people who are watching, these are mainly clinicians, and I think what I would want to encourage people to do is first to have enough of their own experiences with medicine, which I know Living Medicine, you guys do really well. I think you do an excellent job of that. And then also to be in consultation groups, to really bring your case notes in, private confidential case notes that get shared with other clinicians so that we can see what everybody's doing and learn from it. And to have a container where you feel safe enough to experience your own style. Like, who are you? Who do you bring into the room, and how do you develop that part of yourself to be more comfortable and getting trained? And yeah, and the last thing I'll say is that I'm continuing to do groups. So if people are interested, they could find me to do groups.
Great. I'm sure that you do an amazing job at that. And it would be a real privilege for anybody to participate in that. So Erika, I just want to give you my heartfelt thanks. Thank you so much for coming to this and to sharing in this experience with me and sharing with all of us your wisdom and your knowledge and just speaking so beautifully and eloquently about this. I think you do an amazing job of linking together in the experiential component and that clinical and assessment piece. So thank you so much for that.
Well, thank you, Sam. Thank you for inviting me. And yeah, I am very grateful for the work that you're doing to bring awareness and the clinical acumen to this work, and to be out there doing all the good work you guys are doing at Living Medicine. So,
okay. Well, thank you so much. We appreciate you.
Bye.
Bye.
Thanks for listening to Living Medicine. We'll see you again next time. Be sure to click subscribe to get future episodes.